Good afternoon, everyone, or morning or evening, whichever it is in the place that you are attending. I have to welcome you all very much to this session. I'm very excited to hear that there's more than 300 registrations for this webinar, which is great. So I want to welcome you and present a little bit about the EAPC reference group on public health and palliative care, which is the organizer or the co-organizer for this webinar. And I have to excuse my colleague, Luc Delians, who is also chairing this reference group, but who couldn't be here today. And the secretary of the reference group, Steven van der Stichelen, who fell sick this morning. The aim of the reference group is really to create some visibility for and attention to the public health and palliative care and influence the agenda a bit. It is meant to create a platform for it regarding public health palliative care and establish also links with other organizations such as the OECD, the WHO, etc. So we have organized several conferences, seminars, summer schools, focused on research. And maybe good to know is also that we release a newsletter with updates about our activities and on a regular basis. And I'm going to show you how that newsletter looks like. So it's published twice a year. It has an international editorial board. All the issues are focusing on specific themes, and they cover not only academic, but also practice, policy, culture, and arts around public health palliative care. So here's a snapshot of how our newsletter looks like. And if you want to be more informed about all our different activities, you can register for the newsletter. And I think if you scan the QR code here or go to the link on the screen that is showing now, you can register for our newsletter. So I mentioned that we regularly also organize or co-organize webinars, and every 2 years we try to facilitate the organization of a seminar on research in public health and palliative care. And this year, this will be taking place in Belfast, 16th and 17th of November. You can see the date here on the screen. And the call for abstracts for this very interesting research seminar has been opened. And the deadline for the call for abstract is the 14th of July, so Bastille Day. If you go to the link here on the screen, you can submit your abstracts, and we're really looking forward to receiving those. Another activity that we as a reference group are co-organizing is the pre-conference activity the day before the EAPC World Conference in Rotterdam will start. So this will take place on Wednesday, the 14th of June. And it is about connecting communities with a specific focus on the Netherlands. Good to know is that this is a free pre-conference, but you have to register. So please go to the registration and attend this very interesting pre-conference on public health palliative care. So, but today, as a reference group on public health and palliative care, we took the opportunity to organize the first of 2 webinars that pay attention to a recent, very relevant publication to our field. It's the Oxford textbook of public health palliative care. And for today's seminar, we have invited one of its editors, Julian Abel, and the authors of 2 of the chapters of the book. And I'm showing you the timings of their presentations here, and I'm hoping that we can stick to the timings of the presentation so that there is enough time for all of you to be engaged in a bit of a discussion, or at least a Q&A with the different speakers. So I'll first give the word to Julian Abel to present the book he edited. And Julian, he is a consultant in palliative care and is the director of Compassionate Communities UK. So Julian, the floor is yours and you can share your slides.
Well, thank you, Joachim, and it's just a pleasure to talk with you all. I'm going to just have a quick flash through to give you an overview of what this is all about, and then the other speakers will take over. So there's a question about why is public health palliative care necessary, and in spite of all the achievements of palliative care over the last 60 years, some really significant problems remain. There's massive inequity: diagnosis, cause of death, ethnicity, gender, LGBTQ plus, structural vulnerability. When you think about the social morbidities that happen as a consequence of death, and that includes anxiety, depression, loneliness, drug and alcohol abuse, lost school days, lost work days, the list goes on. That happens irrespective of the cause of death and can last for years and leads to physical and morbidities and mortalities. There's also palliative care is deficit focused in that it concentrates on needs and symptom control, whether this is physical, social, psychological, or spiritual. And it doesn't concentrate on the things that make life good: the love, laughter, and friendship, the warmth, the intimacy, the relationships to people and place. Bereavement is specialist focused and not community based. Everyone, without fail, who suffers from loss and grief needs the love, laughter, and friendship of the people around them. And when you look at the research is quite clear. The most helpful form of support is that comes from the community that surrounds them. And then when you look at the research methodology of the bulk of palliative care research, it tends to be reductive rather than engaging in the complexity of human experience. This is a slide which shows the impact of social relationships on mortality, on reducing your risk of dying. And as you can see, social relationships are more powerful at reducing your risk of dying than giving up smoking, drinking, diet, exercise, and anything else you care to mention. And the point about this is that this is biological, that this relates to not just the 2 million years of hominid evolution, but when you look at the markers of compassion and social behavior and kindness, you find them throughout the animal kingdom. This is 600 years of animal evolution. And particularly in humans, survival of the kindest is a much more appropriate term than survival of the fittest. The point about this is that this is a biological phenomenon. There's an incredible paper by George Slavich and colleagues, social safety theory, describing the multiple pathways in which health, well-being, and social relationships are interwoven. The separation of the mind and the body is just entirely inappropriate. And if you want to find out more about this stuff, you can look up the work of George Slavich and Steve Cole on human social genomics. It's an excellent paper in Lifestyle Medicine. And I love this quote because it really helps to give a perspective from the fantastic book by Bessel van der Kolk. Social support is not the same as merely being in the presence of others. The critical issue is reciprocity, being truly heard and seen by the people around us, feeling that we are held in someone's mind and heart. And I would add to that, feeling that we hold others in our own mind and heart. For our physiology to calm down, heal, and grow, we need a visceral feeling of safety. No doctor can write a prescription for friendship and love. These are complex and hard-earned capacities. And you can find all over the world this reflection of community everywhere, particularly in indigenous communities, but also emphasized by Ubuntu. I am because we are. We don't live in the singular. We live in the plural. We live in the context of relationships to people and place. Palliative care professionals by habit and training think about patient first, not networks of relationships. And the point about this is that when you start to take a whole population-based approach, is that you can look at not just the specialist and generalist care, but you can look at communities and the civic life that everyone participates in, and not just in these four sectors, but how they interrelate together. In other words, that when we're thinking about palliative and end-of-life care, we think broadly about everyone and not leaving anyone out, irrespective of cause of death or age or anything. And we don't just think about the person with the illness, we think about those who surround them. Anyone who is involved with death, dying, loss, and caregiving, because that is all of us multiple times in our life until we reach our own death. So the public health palliative care has been knocking around, started by Anne Keller here back in the 1990s, and it's just been growing and growing over the last 25 years. And we thought it was time to write a textbook that covered the whole ground. And what I'm going to do is I'm just going to give you a very quick view of the different chapters of the textbook so you can get an idea of the overview. It's divided into 6 sections, and you'll hear from Julia and Philip, but I just, while I'm talking, you can have a quick read of the slides. I'm just going to very quickly work our way through. The basic concepts are drawn in particular from New Public Health, including the principles of prevention, harm reduction, and early intervention. The nature of what happens is participatory. In other words, you have to deal with power relationships. The basic practice methods are community development, compassionate communities, compassionate cities, end-of-life literacy, and of course, it has to have an impact on international health policy as well as national and local ones. Health promotion, it was initially, Alan coined the term health promoting palliative care to recognize that that communities and health and well-being are all important, and clinical practice methods in particular in relation to primary care teams is really important. And then we go on with population-based approaches, and I'm just going to whiz through these because time is short. There's an ever-increasing evidence base. We're going to need new research methodologies because cause and effect methodologies are really difficult in the context of complexity of human relationships, and we need to look outside of traditional health services research. And then we have a section on education and training and the use of toolkits. What are the biggest challenges? Well, actually, professionalization is the biggest challenge. Engaging clinicians is particularly difficult, and removing the professional mindset, understanding power relationships, understanding that relationships are absolutely key, that actually in community development, compassionate communities, when engaging with local people in their communities is not that difficult, but it's very difficult if you have the obstacle of not understanding it and thinking that professional is the way to go. And education is absolutely key. We've been running courses for specialist registrar trainings and multidisciplinary team clinicians in the UK for a while now. And we find that when you put the clinicians through these courses, and we've also developed echo communities of practice afterwards, is that people can take on this new approach, this large field, and work out how to put this in practice in their clinical environment. So that's probably my 10 minutes up. Thank you very much. And I look forward to hearing more and other speakers.
Thank you very much for that very clear and compelling introduction, Julian. And for those of you who joined a bit later, if you have any questions, we will keep these for the end of the session, because there will be time, a half an hour, for questions and answers with the different speakers. So do put your questions, like Joanne was saying in the chat, in the Q&A section. Then it's now my pleasure to introduce you Professor Julian Verne, who is a public health consultant who has since 1995 worked at local, regional, national and international levels to improve palliative care and bereavement care, and has particularly focused on inequalities in access and unwarranted variation in service quality. She founded the National End-of-Life Intelligence Network for England in 2010 and has more than 100 peer-reviewed publications. She is currently lead for clinical epidemiology at the Department for Health and Social Care, has visiting professorships at the University of West of England and Tbilisi in Georgia, and she is a visiting clinical researcher at the Princess Alice Hospice. Julia, the floor is yours. You need to unmute first, though.
Sorry, just one moment. Can you hear me now?
Yeah, all good.
Yes, apologies. And let me just get on to screen. Thank you very much. So yes, I would like to talk to you about demographic and epidemiological challenges. And the whole purpose of understanding these is to provide optimal care for people that we love, that we care for professionally, and also their loved ones at the end of life. And this is my family caring for my mum. We brought her to my home, but I feel privileged actually thinking about the demographic and epidemiological challenges that we were able to do that. So worldwide, almost 60 million people have been estimated to need palliative care. But yet in 2020, only about 12%, 7 million who need it were receiving it. And prior to the COVID pandemic, we know that the majority of people estimated to need palliative care were suffering from non-communicable diseases. And across the world, obviously in industrialized countries, we've been used to the main causes of death being non-communicable diseases, but across the world, communicable diseases have been a much more frequent cause, and the balance is currently changing. So what are the demographic challenges? Well, first of all, the world's population is aging, and that impacts on the causes of death. The end of life and the final period of life is becoming more complex as people suffer more comorbidity. They have longer periods of frailty, dependency, and dementia is becoming increasingly common as the population ages, and that brings with it challenges, for example, of mental capacity. At the same time, across the world, the birth rate is dropping, and so the dependency ratio is increasing. So there are fewer working people to care for the elderly. We're also in an unprecedented time of migration, which has really complex effects. But the result is we have more nuclear families, very small families, and more elderly people living alone. There are also widespread economic pressures across the world, partly as a result of the COVID pandemic and the war in Ukraine, but for many other reasons too. And this is producing personal challenges. Many more people are struggling to pay their bills, to heat their homes, to buy adequate food. And that impacts on their ability to have good end-of-life care and for their families to provide it. And it also impacts on the cost of healthcare and social care. And then finally, the demographic change that we're seeing is leading to a sort of culture of denial of death, and I'll expand on that shortly. So we have lots of challenges, an absolute increase in the number of people needing palliative care, and of course their families. Different types of care is needed, not just specialist palliative care. People are now experiencing a less predictable course as they approach death, with more multimorbidity, more dementia being important as people approach the end of life. We're also seeing changing ethnic compositions in many countries as migration impacts on that. And importantly, just a small section, we're seeing more end-of-life care being provided in care homes, homes for the elderly and those at the end of life, rather than in family settings. Excuse me. So in England, the number of deaths has been predicted to rise. Of course, we had a sudden blip during the COVID pandemic. And indeed, the extra number of deaths we saw was almost equivalent to the increase that we're expecting out to 2030. As you can see from these population pyramids on the left, in 2040, the majority of people who die will be over 85, well over 85. And there will be much larger numbers of deaths than in previous decades. However, across the country, demographics of different places are different. So on the right-hand side, in the top right-hand corner, we're looking just at the population demographics of Manchester, which is a metropolis, big inner city areas with a very young population, whereas the neighbouring area, East Cheshire, has a much older population. So even in terms of local planning, let alone national planning, we need to look at the local areas. This slide shows the deaths in England in 2021 from the 4 major causes. And importantly, what I would like to illustrate is on this slide, the blue is showing the underlying cause of death as recorded on the death certificate. And in England, we also register contributory causes. So you can see that for cardiovascular disease, almost half the people that die with a mention somewhere on the death certificate of cardiovascular disease have it as contributing to the death, not as the underlying cause. Or a third of those, almost 2/3 of those with respiratory disease. So this is illustrating that people increasingly, as they die at older ages, have complex causes of death. So 9 out of 10 people who die currently in England will have a mention of either cancer and or cardiovascular disease and or dementia and or respiratory disease on their death certificate. So domination of non-communicable disease, but also complexity. We look at key indicators which are determined by the demography of the population to look at need. So, for example, in England, currently, 2.5% of the population are aged 85, but as I'll show you shortly, that varies geographically. 14.2% of older people are currently living in poverty. It's a shocking statistic for England, and that also varies geographically. And almost a third of older people over 65 are living alone. And that provides significant challenges to support people. That's why we need community resilience and community support to care for people at the end of life. So this illustrates the point. It's showing the percentage of the population aged over 85 in England at very small geographical areas. And you can see the dark blue is representing where it's between 3 and 12%, the highest proportion of over 85-year-olds. And it varies significantly geographically. You can see that there's a predominance in coastal areas. And in coastal areas, there are fewer young people to care for older people because the younger people migrate to urban areas. And that provides significant challenges. This slide shows the variation in proportion of older people over 65 living alone by region. And you can see in Bordeaux at the top that the London region has the greatest proportion Despite a wide variation shown by the interquartile range of the box plot, the greatest proportion of older people living alone. So in London, we find that more older people die in hospital because they simply don't have the support to be cared for at home. However, a bit of good news, demographic good news. As you know, in general, women live longer than men, but the age at death for men is catching up. So soon we will have more perhaps very frail couples living towards their end of life. And so the challenges will change from caring from single people living alone to more couples or groups of people living alone who may be, though, very frail. And this slide shows the proportion of people living in poverty, elderly people, in one area of the north of England. So the England average is 14.2%, but in Hull, one very deprived area, a quarter of the elderly people are living in poverty, relative poverty. In terms of demographics, we're also seeing a change in England and Wales in the proportion of people from various ethnic groups. So we've had many waves of migration in England, and migrants are aging in place. That means that as we provide care for an increasingly elderly population, it's also becoming more diverse. And that means we need to pay more attention to people's cultural, religious, spiritual needs, and the way they want to care for their family. One of the big challenges is the dependency ratio. So this is the relationship between people of working age and people who need caring for. And in this case, it's calculated taking into account also children. But you can see for Europe that we have more and more people who are dependent on the fewer and fewer people who are of working age, but it's a worldwide phenomenon, and other regions of the world will catch up with the European challenge. Because we have fewer people, family members, for example, to care for the elderly, we are now more dependent on social care to support health service care. And this just shows the projections of different age groups in two of the northern regions of England, but also is showing the likely increase, proportional increase in number of care workers we will need. And where will they come from? Will they come from our population growing up here in England, or will people come from overseas to support our elderly people? But that, of course, then deprives those other countries of having young people to care for their own elderly. And indeed, we can see some of this happening. This is just an updated data from June 2022, showing the numbers of people working in our National Health Service from different countries. And you can see that we have really significant migration of doctors, nurses, care workers. We need to consider what that does, though, to the countries that they come from. But in general, migration is having a big impact on the dependency ratio, but also the numbers of people in place to care for their elderly. And I know that pre-COVID, for example, from Romania, 3 million young people emigrated to other countries in Europe. During COVID, and perhaps also as a result of Brexit in England, many young Romanians either returned home or went to other European countries. But there are multiple reasons why people are moving across the world, and that has an impact both on the care provided in some countries and the lack of care in others. And finally, the fact that we are also living longer means that we are becoming less used to death. And I've got two important quotes here, one from Norbert Elias from his book, The Loneliness of the Dying, which says that the attitude to dying and the image of death in our societies can't be completely understood without reference to the relative security and predictability of individuals and our life expectancy. So as our life grows longer and death is postponed, the sight of death and dead people is no longer commonplace. And so what he says is it's easier to forget it. And Zygmunt Bauman also referred to modern societies denying and deferring death. by turning the inevitable ending of life into lots of small battles, non-ultimate and potentially resolvable health hazards, so risks to our death and illness. So we no longer think of death as being inevitable. We see death as being a fight. Can we defer it? Can we defer it? And this, plus changing social norms, such as reduction in religiosity and reduction in cultural traditions, means that it becomes much more challenging for people to face their own death and their families to deal with bereavement. The COVID-19 pandemic was a big wake-up call. On the left-hand side, you can see the sheer horror of the graphs, with the yellow showing the peak of death in care homes in the first and second wave, and blue in hospitals. And in England, we experienced almost as many additional deaths in a year as we were predicting that increase by 2040, mostly in elderly people, and death came shockingly, unannounced, unexpected. But what we did have was that many more non-specialists, both health and social care, had to provide most of the care. And we saw particularly rises in deaths, not just in hospital, but at home and in care homes. And bereavement was really complicated. This graph shows that at the beginning of the pandemic, so in April, May 2020, for people dying from cancer and the 4 major causes, that for almost the first time, home became dramatically the preferred place of death. Now, we don't know if it was all personal choice or whether some was encouraged by health service professionals, but that increase in death at home has persisted. So we need to change already the pattern of the way we're delivering palliative care for the most common cause, which is cancer. And that impacted on ethnic groups as well. So prior to the pandemic, more people with cancer, excuse me, from Asian backgrounds died at home. But there was a bigger increase, excuse me, during the pandemic in the proportion who died at home. And that applied, as you can see in this bottom right-hand graph, to all age groups. Similarly, we saw increases in deaths at home in those from Black ethnic groups and white as well, but the biggest increase from the highest base was in those of Asian backgrounds. And we need to take that into account in terms of the way we provide multidisciplinary palliative care and community support. But there were also impacts in terms of deprivation. So prior to the pandemic, more people from the most deprived fifth of the population died at home, and that dropped as for everybody else. But the highest proportion of people who die at home were in the least deprived, so the most affluent group, and that increased most significantly. But I'd also like to draw your attention to the fact that even prior pandemic, in this first little blue bar, fewer people from more deprived backgrounds die in hospice. And that is clearly something we also need to address. But it wasn't just people dying of cancer, which is more predictable, that increased at home. We saw also increased home deaths for dementia. Now, very many fewer people with dementia die at home than with cancer. However, the proportionate increase during COVID and persisting post-COVID has been greater than the increase for cancer deaths. But let me draw your attention to the fact that in England, more than half of the people who die with dementia and Alzheimer's die in care homes. So COVID was a wake-up call, and we've got significant lessons to learn about better integration of palliative care with public health emergency planning. And I've had my lifetime also of public health emergencies as a public health practitioner, but I know that we need more emphasis in our planning for future disasters, pandemics, and so on. We need more integration of palliative care in terms of communication, training for everyone, social workers, health workers, general population in palliative care, making sure we've got good drug supplies, mortuary facilities, and better training for funeral directors, but specifically to attend to the vulnerable and make sure they do not get left behind in the next big disaster. As the Director General of the World Health Organization, Worldwide Hospice and Palliative Care Alliance said, the COVID pandemic has highlighted the importance of palliative care in all care systems. The need to relieve suffering, difficult decision making and complicated grief, which we saw during the pandemic, are exactly the types of problems that palliative care was designed to help address. So post-pandemic, and in the face of significant demographic and epidemiological change, there is evidence of a new spring for end-of-life care, for palliative care now to become a civic responsibility, not just a professional one. And really, we have the opportunity to develop these partnerships now. Thank you.
Thank you very much, Julia. I think that gives us a clear overview of the different challenges we have for public health approaches to palliative care. And for those of you who joined later, please put all your questions in the Q&A, and we will address all the questions during the Q&A in the final half an hour of this session. There's one clarification question to Julia in the Q&A. Perhaps you want to address that now before I give the word to Bill. It's about the deaths in... Yeah,
thank you.
Go ahead, Julia.
Thank you. Yes, Donna, it is any respiratory disease excluding cancer. It doesn't include COVID-19. And it's whether it appears as the underlying cause or a contributory cause. So the main diseases in that group are COPD. Asthma will be included, but it's not the main body. Pneumonia as well is included. Thank you.
So thank you very much, Julia. And again, I put all your questions in the Q&A for Julia, and we'll address those later. So now it's my pleasure to introduce the next speaker, which is Bill Larkin, who was the former president of the EAPC, I have to say a very good one. And he is currently working as a professor at Lausanne University Hospital, and Phil is addressing the International Palliative Care Policy.
Thank you very much, and thank you for the invitation to be here today. Sorry, I put my slides up a little bit quick there, Julia. My apologies. So I, no conflicts to say. I wanted to talk about three things, some of which has already been addressed by Julian and Julia. So in the interest of time, I may skip over some of those. But basically, I want to really try and address three questions. Does international palliative care policy actually exist, and is it important? Is there a risk if a public health palliative care approach is undervalued? And particularly, is the messaging right in terms of access to palliative care, and particularly around human rights and justice? Because I think some of the international palliative care challenges are how we explain who we are and what we do. And if it's not a clear message, it becomes very difficult for policymakers and politicians in particular to understand what it is that we're trying to sell as a model. Sorry, it doesn't seem to want to move. There we go. So Julian's already introduced the book, and I think that some of the points about this that are very important is this idea of focusing on community development and partnership, and that we can't separate the challenge of social model, social health within palliative care. We have focused largely on the management of the good management of symptoms, and I'm going to refer to that, but we do need to think about where community sits as a support agency and a tool to ensure the best possible end of life. And therefore, I think it's helpful to consider palliative and end of life care as a spectrum, as a trajectory, so that you can have different levels of intervention at different times. However, at the international level, as I'll make a point at the end, we can't forget the importance of end-of-life care, because for the majority of people, that will be the only option they will have for palliative care. So what are the challenges? Some of this has already been said. I think we know that 87% of the world population still can't access palliative care. We know that there are particular challenges when you try to transfer developments from higher income countries into low and middle income countries because simply the fit is just too difficult. But I also want to make the point about the work, and I'm going to refer to it in this presentation, of Joseph Clark and colleagues from the University of Hull in England, where they're developing a hub around international palliative care policy. And the point that he makes here, which I think is really important, is that palliative care is developed through civil society action and not necessarily political leadership. And I think the message there is, whom should we be targeting with our messages about what we should be doing in palliative care? And that really goes back to the community approach that has been led by Julian and others in terms of the compassionate societies. Doesn't seem to want to move. There we go. I also, of course, want to mention the reality of pain management, which is still critical. We still see cancer pain as emblematic of serious health-related suffering, but we know at the reality of we see patients with a much broader context. I think the point about this slide is that 50% of the world's population will receive less than 1% of the total opioids available. And the countries that are most likely to provide us with the opium to make our opioids are the same countries that are least likely to be able to access that when they need it. So I think there are significant issues of equity there, which we have generally failed to address. So what does that mean? And I come back to the work of Joe Clark and others. Citizens have a right to optimal palliative care. How that is defined may have a cultural context or may be developed or defined in different ways. But where there are situations of weak democracy and political instability, palliative care often falls off the table because there are other priorities. And we know, I'm going to talk about one good example where that's work, where it's been reversed in a way. But there are some challenges that we have. And one of those is the fact that in the Sustainable Development Goals, although palliative care is mentioned, there are no clear indicators. And so for the political level, there still is a lack of visibility about what palliative care can potentially offer, even though many of the international policies now, and I think Julia referred to some of those as well, that say that palliative care is absolutely integral to our population health, but the indicators are often missing. And I know the EAPC has One Voice, One Vision as its title, its label, but I think we need to think a little bit more about, do we really have one voice and one vision in advancing this political agenda? So what do we need to address? Well, I think one of the challenges at the moment is that we still have some divergence in thinking. I think there would be a group who feel that our focus should be towards the establishment of clinical organizational excellence, palliative care as a specialty within palliative medicine, for example, guidelines and standards, very important. On the other hand, there is also a group that would say we should think more about now the social model of care, lobbying for global access and equity. And if you look at the three main international organizations involved in palliative care, generally they sort of tend to focus on one or the other. I think one of the interesting things is, to the best of my knowledge, and I may be wrong, I have never seen a policy paper by all the organizations come together to say, what is the way forward for palliative care? My worry is if this divergence continues, the divergence will become more difficult and it will be harder to find our way back to create those consolidated messages. One of the challenges I know in particular has been brought up in the United Kingdom is the place of hospice, which is obviously that fundamental part of what palliative care started out as, the work of Cecily Saunders, etc. And questions around our current models viable. Now, I think we, and particularly at the international level, we do need to think about the transferability of models. We need to think about how to develop a model which is culturally sensitive, as Julia has also mentioned. But we also need to consider what exactly is the place of hospice, because it always seems to be an outlier in terms of the planning. Some countries think it's very important, others think it's less important. And of course, there's also a challenge here of how hospices are funded. The reliance on charitable finance doesn't actually support the strengthening of a good palliative care model, and hospices tend to be the poor relation within that. But I think we need to think about this. If we think of that trajectory of palliative and end-of-life care, then we do need to think about what is the contribution of hospice within that. I am pleased to say that there has been some shift in WHO. So if you look at their recent palliative care facts, you can start to see a little bit more this language around universal health coverage, the role of primary health care. But there is still perhaps a little bit of a sense here of the clinician providing as opposed to working in partnership with. And so I think there is a move in WHO, but I think we could help them move a little bit further to see how communities can take more responsibility and be in partnership with clinicians. I want to make a particular point about the EAPC because they were very visionary in challenging the original definition of palliative care and saying, some of the issues that are related in this book are very important, that we see the holistic range of people, that we try to address people, enabling them to fulfill their goals of care. It's almost trying to change that. And I think this is a very important message. However, I think the risk is if we have too many messages, it's very hard for the political people to understand what is more important. And it can be hard for the advocacy people to sell that model because they're saying, well, this is one way of thinking it, but there are others who think in different ways. Not everybody will agree with every aspect of this, but we need to have some commonality of definition, I think. Research has already been addressed. And again, I know that this group in Hull have looked very particularly about the risk that palliative care research is becoming quite funneled and how funders pay for palliative care research. Some of the big questions which are around international development may be struggling to get funding because people are looking more at very, very specific foci of research around symptom management, and so it can be quite difficult to get a handle of how you get the research agenda beyond the generic research field into an international development arena. But it is something to consider. I've spoken about this before, the idea that palliative care is a human right. It's well documented in the literature, but I think there is a challenge. And the challenge is, who is responsible for human rights? There are agencies like Human Rights Watch that take on this responsibility, but it's very hard to police that. And in fact, some of the more recent literature is arguing perhaps human rights is not just the correct term to use here. Maybe we should be looking more at issues of social justice. And politicians and policymakers respond to the language of social justice, particularly when it comes to election time. So it may be that we need to reframe a little bit what the message is around the human rights debate. I'm not denying it's important, but maybe it's a more difficult message to sell to the people who make policy. And I just want to reflect this colleague of mine from Dublin, Kathleen Lynch and colleagues, who've written a number of books about equality. And she argues in this book that for a real social justice model, you need three things. People need to have a sense of value and belonging, which she calls love. People need to have the skills to care. And I think that's a very important point when we're asking communities to take on responsibilities for care. Have we given them the support so that they can learn those skills if they wish to? But most importantly is solidarity, which is an independence on each other. And those three elements, if we can use those to frame the messaging of palliative care at the international level, it may be more meaningful and make more sense when if you like, the aspects of early intervention, for example, which are very laudable in the Western context, are simply not feasible in other contexts. So I think we need to think about, are there different messages, different models that we can use to determine who we are as palliative care? Now, as I said, it's not all bad news. We know the WHO resolution was very good in getting systems and health systems to think about strengthening palliative care. although the examples still are quite new and limited. It is noted in global health priorities now, although I mentioned already the point about this, the Sustainable Development Goals. And we are starting to hear some disparate voices and some evidence of a shift in language. So I think in small ways, we are getting some of this message across about how palliative care needs to change. Very briefly, I just want to note two examples. I refer to this one in the book chapter I wrote, which is called Todos Contigo, altogether. I think my Spanish is not good, but this was a Spanish development that actually then was sent to Colombia. So this project I'm talking about is based in Colombia. Now, the reason I wanted to mention that is it's an extremely good example of how a community-led initiative in palliative care can be developed in a situation of relative political instability. Colombia has challenges in its political system, but it has been able to develop sustainable messages, sustainable projects, particularly with populations that are underserved, marginalized, or vulnerable, because it's based on social awareness and training. It's empowering communities to find local solutions to their needs and create sustainable models. They developed also an observatory so that they would provide evidence. And this was the bit that the policy people needed, the evidence to show that this model worked. And they were able to do that through best practice identification, best practice evaluations. There are similar models in many other countries. South Africa has a very good model of this type of using observatories to gather local data about whether or not the project is working. And they also went on to look at this at a more national level, the Declaration of Medellin in 2017, which really got us to focus around the social context of death and dying, that we don't separate our population from the people whom they love, that people have rights and optimal rights about where they die, and that their dying should be kind, humane, and respectful, and that we as citizens have responsibilities here. So I think that in a way, this is a good example of the whole community approach, which is sustainable irrespective of the political situation. Of course, that will always have an influence, but to be aware, it is feasible. The other thing I wanted to mention, which is probably more where I often work in, is around pain and policies, and do a lot of stuff with, well, I've done stuff with Jim Cleary in the past. But I think this is really a very good project, which has tried to say, yes, we need to look at the availability of pain medications, but the thing we also need to address is how to avoid exploitation and abuse. So it takes, if you like, a social model and a clinical model and tries to bring those together to provide solutions, to provide greater equity. And it acknowledges the complexity and the partnerships that are needed. And it's done things like international pain policy fellowships. It's done train the trainer programs so that things can be rolled out at local level, and it shows that things can be possible, and partnerships between the higher income countries and the low middle income countries are feasible, providing that it's understood about what is actually transferable from one to the other in terms of outcomes. So coming to the end of my talk, I think we've already discussed this importance, but this is, I think, a very important paper by Kane, which is how we see community as an expression of culture. And not necessarily, it does talk about race, ethnicity, and culture, which is extremely important in the way we deliver palliative and end-of-life care. But how do we learn what people want? How do we engage ourselves with the community to understand their preferences, to understand their patterns of communication? And how do we live with respecting difference in decision-making? There's always a risk of a professionalization model to come. And I think that's part of that divergence discussion I said earlier. We have to almost change some of our mindset to be able to embrace a new public health or a new palliative care. And I also look at Debbie Horsfall's work, which is really looking at how you develop place-based networks, caring networks, which talk about equal and respectful partners. And that also includes the clinicians. We're partners in care. We're not just the deliverer of care. But that's a language thing that we need to change. And at international policy level, we need to try and see this to be more visible in the way in which documents are prepared, meetings are held, policy briefings are organized. And there are some very good examples of that. So in conclusion, I think we need to make sure that we condense and coalesce our message about what palliative care is. I'm no longer a good example. I'll just be a terrible warning. I think it's very important that our warning is that if we don't find ways of doing this, I think that palliative care risks some serious problems in the future about their sustainability, particularly with the advent of the idea of the generalist approach. Where is the place of the specialist in that? I think we need to avoid what we call, I live in the French part of Switzerland, so we are very good on the millefeuille pastries. And I think that we need to be careful that we don't just see palliative care as a nice treat on occasion for people. But if you ever see them make this, there's often an important need for a careful balance between the pastry and the cream and the jam. It needs to come together carefully. If you just add extra layers and more filling, it just falls apart. And that's a metaphor, I think, that we need to hear. If we keep adding new definitions, new levels of information, but we're not actually integrating them in what's gone on previously, I think the risk is that something could fall apart and we could find ourselves in a very difficult position. I've already said that we need to see end of life as a world perspective. The majority of the people of the world need palliative care, as we know, but they will need it at end of life because that is often the only place that they can get. So we need to be honest about the language that we give around what palliative care delivers. Is it realistic to be saying, to talk about, for example, early intervention in countries who have limited income, limited resources, and where they have high levels of elderly, frail people who need palliative care at the end of their life? And my last comment really is just to go back to the work of Julian and this paper that's just published in 21 on access to palliative care. So I think the messages really around international policy are focusing on community strength and assets, the strengths of your community, learning how we share our expertise and wisdom, and to embrace a creative way for seeing what it means to be diverse, so that we're not just focusing on one Western view of what palliative care is, that we can accept and embrace diversity and learn from models of community development, I think, as Julian has already said, because I think that they would teach us a lot about how we can create this new public health approach to palliative care. So thank you very much for your attention.
Thank you very much, Phil, for that excellent and broad presentation that really clearly maps the different policy challenges and wisdom from you. As said before, we now have about half an hour for a Q&A with the different speakers. And I have been monitoring the Q&A. If you have any questions that come up during the discussion, please put them in there. So I've been monitoring the Q&A, and I have also received a number of questions that have come in through the EAPC portal prior to this session. There's one very practical question, which was about the availability of the slides after this session. If I'm correct, Joanne, the session will be available after this as a recording, or
yeah, we can make the recording and the slides, if the presenters all agree, we'll make the slides available with the recording. Yeah.
So that addresses that very practical questions. Now I've been trying to cluster the different questions that have come in a bit into different groups or themes, and I think a lot of the questions related to the issues of money or funding for palliative care. And I'm gonna read a couple of those, and then I'll ask the different speakers to address whichever one they think is they feel comfortable with. So the question is how to request more budget from the EU for palliative care. There are massive funding gaps in this area, so public health palliative care, particularly for those who want to remain cared for at home. What is the ideal model? Why don't international institutions force their governments to include specific resources for palliative care? I'll continue. How to persuade the the importance to finance a home palliative care service and include it in insurance-covered care services? And how can policy professionals be more effective in making a case for investment and strategic planning in palliative care? So you see, there's a number of questions that relate to funding, and the different questions tackle, I guess, different elements. But any of the speakers want to address some of these funding issues? Julia, please go ahead.
Thank you very much, Joachim, and colleagues who've posed those questions. So, I mean, one of the first and most important things is making the case. And one of the best ways to do that is with epidemiological data. So please work with colleagues in your countries who have access to data, because actually showing numbers and the magnitude of the challenge faced by the health service makes a big difference. As I showed you for England, but some similar results have been found in other countries, that as a result of the COVID pandemic, more people died at home. However, more people are continuing to die at home, a higher proportion than prior to the pandemic. Now, this was an aim of our national palliative care policy in England, to support more people to die at home, but overnight there was a stepwise change. However, the resources in the community are very stretched. So we are making the case that there need to be more resources in the community, not only healthcare, but social care too. And one of the ways we doing that is also by analysing the number of admissions to hospital during the end of life period, for example, the last 90 days. And we have a key performance indicator, which is 3 or more emergency admissions in the last 90 days, the last 3 months. Because while some patients really need those emergency admissions, many of those repeated emergency admissions occur because people aren't thinking that the patient is now entering the final phase and not providing sufficient help at home. And what we can demonstrate is if there is better palliative care and end-of-life care and social care support at home, patients require fewer hospital admissions, and hospital admissions cost a lot of money. We can also show that length of stay during periods like 6 months or 3 months at the end of life, the number of days in hospital can be reduced. So you need epidemiological data supported by economics. And that really helps to make the case for more home care. Thank you.
Any of the other speakers want to address any of the funding issues? I mean, this is a big issue, of course. Julian.
I mean, I could say something at the EU level. I could say quite a bit about at the EU level. I mean, the problem, I think, the problem in one of the questions was, you know, how do you force people, the EU, to give more money? Well, the problem is the EU represents, and it depends how you calculate the number of countries the EU represents. But the problem is that they have to, the EU don't actually necessarily have the budget. The budgets rest with the countries. What you have to think about is, how do I make myself visible to the policymakers and the decision makers? Now, I would often say you need to think about the politicians. So are there ways in which your advocacy, if you've got advocacy people working with you, and I think that's a really important element, if you can develop somebody who's got skills in advocacy. But my experience has been, yes, it's important to link in with the politicians, but the politicians will change because they're put there by the public. The people you need to link with are what we often refer to as the civil servants, who are the people who are generally there all the time and feed the information to the politicians. So if you want to get change, you need to find who those people are, who are usually somewhat hidden within the system, and focus on those people to get the politicians to get the ear. Sometimes you can be very lucky. When I was the president of EAPC, we got an approach by one of the political parties in the Dutch parliament, and we ended up being able to do some presentations in Strasbourg and in Brussels. But that was opportunistic. If you want something about funding which is much more structured, you absolutely need to work at that level. And then you, of course, you embrace the politician and you get the politician to understand the nice story that goes behind it. But the hard work is the one before. However, can I just say, the other thing I think that will only work is when, and I've said it already, when the organizations responsible for palliative care at an international level come together with a cohesive message about what palliative care is, because at the moment, I feel that the message could be clearer.
Thank you, Bill. I have another question about that, but first hear from Julian.
So I take a slightly different view on this because the bulk of our resources for palliative care goes into professional organisations. And yet when you look at, particularly in the UK, who has access to these resources, it's the minority of people. Often palliative care excludes more people than it includes. And I think that that rather than thinking palliative care needs more money, we have to think differently. And we have to think about what matters most, about how we engage with communities. Because it's an awful lot of what palliative care services currently do, which is not even done best by palliative care services. And we can think about community mobilization, doing what communities have done for the last 200,000 years, which is looking after people who are undergoing the experiences of death, dying, loss, and caregiving. That's the thing that we've lost. And that's the thing that we have to return to. And I don't think that pouring more money into palliative care resources is either the most efficient or the most useful way of approaching that problem. There's another really bizarre thing about this, which is when you take a community approach, costs drop significantly. And you can look at the example of the fantastic work of Suresh Kumar in India, in which microfinancing, children giving 1 rupee a week, that's how the palliative care services are funded. And that in the process of that microfinancing, people become engaged. And I think we have to think really differently from just assuming that more professional resource is going to solve the problems that we face. It's not that professionals aren't needed, but we need to do what the Ottawa Charter for Health Promotion says, the 5 action points, 1986, this is a long time ago, is that services, health services, need to reorientate what they do in the context of community.
So thank you for that addition, Julian. And I think I can reflect a little bit about that also from what I see happening in the Belgian situation. I think there's a realization in Belgium that indeed we also need to go for this more radical transition in terms of palliative care and adopt a much broader view where different professional groups, but also civic groups become responsible for elements of palliative care. And then what I see happening indeed is that the whole history and debate about funding is a bit ambivalent, because on the one hand, you have the traditional sector, or those who make up the traditional sector of palliative care are requesting more funding. But then if you invest indeed more funding to an existing service, maybe that can create a barrier to actually achieve your big transition, because what we need is a bit of a radical change and different paradigms in palliative care. And on the other hand, I also think that if you don't put any funding, if you don't give any incentives for new collaborations, new networks of collaborations to be created, and I think you need to do that as a government, then it's also difficult to go for that big transition. So it's a bit of an either or. So maybe any reflections on that difficulty? And yes, we are asking for more funding for palliative care, but on the other hand, yeah, maybe the funding maybe the carrot needs to be put elsewhere.
Yeah, I agree with all of you, everything you said. I think there does need to be more funding in the community, not necessarily though, sorry, maybe I wasn't clear enough in my answer, not necessarily for, it's not for specialist palliative care, but it's for all the other support to boost the training of GPs, of social care workers, of community organizations, but also, as you're saying, Joachim, to support infrastructure so you can, and linking with what Julian and Phil has said, is to support infrastructure so you can actually bring in community partners, because they too need training and an infrastructure to support them. Somebody needs to coordinate care, and whether it's at 2 o'clock we need the district nurse, but at 6 o'clock please could somebody from the community go in and make sure this lovely person has their supper. Still needs coordination. So we need more funding in the community, outside hospital, outside hospice buildings too, but in the community, but supported obviously by community mobilization. Thank you.
Thank you, Julian. Phil, you want to add something?
Well, no, I mean, I think, yeah, absolutely. I think some of this is a little bit what I was trying to say about the models of palliative care that we have. You know, we need to re-envisage them. We need to review them. We need to, yeah, I think I feel there's a little bit of a fear of letting go of the past, if you like, because we're not sure what the future holds. But I think sometimes you just need to be a little bit radical. And, you know, there are, I mean, I think, you know, the example I often think about, although I know it's only in one part of Spain, but it's the model in Catalonia, where they had a very good model of integration of funding within the health system in Salud. I think that is certainly a way to go. But that was really about a lot of political engagement to get people to understand what the message was. And I think it isn't universal across Spain. You know, there are pockets of excellence. We should learn from those, I think.
Okay, there's a bit of a related question that now just pops up in the chat I see, and does the role of unpaid carers be more explicitly acknowledged and embraced by communities and by professionals?
So this is kind of I think this is one of the things about the language of all of this, is that when you talk about carers, that actually what you're focusing on is around physical needs. But actually in the context of, you know, if you're not approaching it from a professional context and you're thinking about looking after the person that you love, and you think about the kind of things that you need, and and it's not just hands-on care, it's the support of friendship, of people in the caring network, of people dropping meals by, of the warmth of heart that goes through the whole process of death, dying, loss, and caregiving. That at the same time as there's loss, there's love, there's intimacy, there's friendship which lasts for years, there's connection and community, and these are not to do with paid or unpaid roles. This is what we do as human beings. It's how we support the person that we're closest to who is dying, and how we support our friend who is caring for the person that they love who is dying, and how the community comes together and how the civic sector comes to do that. It's what happens in our workplaces, in our schools, in our places of worship, in educational institutions, in civic spaces. It's all of these things together. And I think if we, you know, when it comes back to that reorientation of health services, until we really engage in that civic community life and understand that that is the main place where death, dying, loss, and caregiving happens, we are always going to be faced with using this professional language. And when we use professional language, we instantly head towards inequity and colonization. And I think it requires us to completely step back and think about what made the biggest difference when I looked after my mother. And it wasn't the professional care. It was a love and the friendship of the people around. And it's not to do with unpaid or paid carers. It's not that we should ignore that. It's that we should embrace this different perspective that sees life and death together. It's not about advanced care planning. It is about living well. And if you look in the research literature about what living well means in the context of palliative care, not just for the person, but with the people who surround them, that research literature is not just sparse, it's absent. It's absent. We have made the assumption that addressing needs and symptoms, whether they're physical, social, psychological, or spiritual, equates to so-called quality of life, but it doesn't. And it outside of the field of palliative care, this is well described. And Phil mentioned absolutely correctly social justice, human rights, and the Sustainable Development Goals, because they are all facets of the broader aspects of what makes a good life. And we need to focus on those things. Once we do that, we can think about what is the role of professional services and not make the assumption that the professional services are the highest quality of care.
Thank you. Maybe let's move into a second big theme of questions, which I think relate to the question on how to integrate palliative care and public health. And there's a couple of questions here. I'm going to read them. So how can we integrate public health and resources in palliative care? And how can we integrate a public health approach to palliative care in a nursing home setting is one question. And then there's a couple of questions related to low and middle income countries. So how does the public health palliative care look like for sub-Saharan Africa? Or another related one is, what are the challenges to start practicing public health palliative care and the possible solutions in the context of low and middle income countries? So panelists, any of those questions you would particularly like to address?
I mean,
yeah, go ahead, Julian. Yeah.
Just a short answer. Many indigenous communities do this well. And Ubuntu, I am because we are, and the fantastic examples of Christian Tizimira in Rwanda about how this is done, and the incredible example of what happens in Kerala. And then likewise, the fantastic example of Mary Lou Kelly and Holly Prince, and about First Nations palliative care and how that project developed. It's not just that low and middle income countries do it in a different way. There are many things in those places that we can learn from.
Julia?
Thank you. So public health is all about a number of things that you've already heard about through my fellow presenters. One is about promoting health and well-being right to the end, and that of the families. It's always about it, whether it's prevention of cardiovascular disease or promoting well-being in death and dying and for amongst families. It's also about inequalities, so identifying where there are social injustices, which groups are not getting access to good end-of-life care. And it might be because people come from certain sections of the population. And this applies right across the world to, the people on lowest income, people from different ethnic groups, people who live in rural areas as opposed to cities, or in, as I showed, in coastal areas as opposed to urban areas. So public health is all about identifying who isn't getting their fair justice in terms of end-of-life care, and how can we address that? And it isn't usually only by the medical model, oh, let's give them some more of that. It's about understanding what different communities need. But there was a tiny quote on my slide, which I can't remember properly, from Zygmunt Bauman, which is about the disgrace really of, you know, it's not groups that don't have social justice, it's a disgrace when they don't. So we don't talk about them just being marginalized. And that's what we've got to carry in our hearts. It's important that everybody should have a peaceful and good end of life for them and their families. And we need to identify where there are injustices. And that's what public health is all about. It's about populations more than individual patients. Thank you.
Thank you, Julia. Bill, any further thoughts on integration?
I think that's, I'm starting to wonder, is integration even the right word? I mean, if we want to transform health services and we want public health to be the fundament of what we do, I'm thinking of my pastry and where that fits, but I have a sense that it's really about a radical reorientation that we need to think about. But the other thing I think we have to be very careful about, and I'm always very cautious when I start talking about high income and low income countries, is that I live in one of the most wealthy countries in the world, in Switzerland. And it's all very well for me to sit here in my nice apartment in Switzerland and talk about the needs of people in low and middle income countries. When in fact, the example I can give you is a few years ago, I went to do some work in South Africa. I was teaching in Johannesburg and particularly in Soweto. And in the township, all around me were these tents. And these were people from Zimbabwe who had left Zimbabwe because of the political instability there. And these people were non-people. They were not actually registered in any way in South Africa. They were just there. I don't think we can often understand the enormity of challenge that exists, the instability that exists. And we have to be careful if we come with a particular lens and don't listen to what the community are telling us. Because I think it's, you know, we come with our little bag of knowledge in palliative care, and then we try to sort of like sow a few seeds here, there and everywhere, when actually those people have been sowing the seeds for many years in their own way. We need to learn what it is learn from them. So it's not about me going to teach, it's for them to tell me, and I learn more in that context. So I just think we need to be, but in those of us who work in the privileged element of where palliative care is, need to be careful how we put labels on different systems in different countries, which may have different challenges. That's just a comment from me.
So, I suppose it's a bit a matter of not forcing our frame about palliative care and public health palliative care on others, and I'm trying to create a big transition there, because that will be hopeless. Will probably not succeed. It's more about allying with a coalition of different organizations who have relevant expertise, and to just add our topic or add our expertise to those coalitions, because what we really need is a big democratic transition. Also, it's about new paradigms regarding representation, about social justice. So I think we cannot do this alone. That's basically also what you are saying. Yeah. Julia?
Yes, could I just mention, it's also reflecting on something one of my co-presenters mentioned about the wonderful initiative in Colombia, that sometimes in times of real adversity, there is also opportunity, and real instability, there is opportunity for better end of life care. So in Poland, during the martial law, when communist regime imposed even more harshly in the late 70s, the home care hospice movement sprung up, and people went undercover taking opiates and visiting people in their homes. And it was really the foundation of home care from the Gdańsk area. So sometimes where there is real difficulty, great compassion and new models of care can evolve.
Julian?
So I think Phil and you, Joachim, have made a really great point. And this happens when we look at inequality. We see that palliative care is riven with inequality. It's an ongoing debate in the UK, and in particular, when you think about the variety of different inequalities that we mentioned right at the beginning, the question is, can we, as professionals, ask questions of humility, with willingness to discover what is already great in communities, and not assume that our model of palliative care is the one that everyone wants, because it may be irrelevant. And Phil's point about townships in Soweto is, that's absolutely right. What is already there? What is it that engagement with community? Let's discover what community wants. And I recommend looking at Mary Lou Kelly's project with First Nations community, because she exemplifies this approach about discovering the strength in community. And I would finish this with saying, I run a podcast called Survival of the Kindest. I interviewed Holly Prince, who was part of that project. And when Holly first came across public health, palliative care and compassionate communities, she said, somebody asked her, where would you see compassionate communities in 10 years' time? And her comment was, well, I hope they manage to catch up with what's already happening in our community. Compassionate communities is a natural human development that we've somehow lost.
Good point. So I think, Julia, maybe if you can make a final comment, because I think
very quick. How could we incentivize it in a time when people are, worried about economic problems and are working more and more hours? I mean, we need to think about other incentivization. I know this sounds weird, but to recapture the opportunity for working people to devote themselves to the community, we need to have some sort of incentives, or at least permissions and more flexibility in the workplace to enable that to happen.
Thank you, Julia. And I think we are almost running out of time. And I think Joanne from the EAPC has some final comments that she would like to make. But I want to thank all the speakers for their excellent contributions and an excellent Q&A. And I want to thank you, the audience, also for your contributions and questions. So I think this was a very good session. I'm also looking forward to seeing you for the next. I mentioned this is the first in 2 webinars. There's another one coming up, and I forgot what the exact date was, but which will also have some speakers and authors of the book that Julian has edited be contributing to this session. So